Hey, Delaney.
Morning.
Hey, Rachel.
Good morning.
Morning, Kylie.
Good morning.
Morning, Maya. Hey, Dana. Okay, so it looks like it's 8:30, so I'm just going to go ahead and get started. So we have 3 chapters to get through today. It's 15, 16, and 17. And believe it or not, we're almost done with this OB stuff. So after today, I think we have 2 weeks left of OB stuff and we're done. So next week, just to remind you, we have an OB ATI proctored test. So I wanted to ask you guys, did you from last term, because I think you had mental health last term, did you have to download that Proctorio?
I don't think we had to download it. I think it just kind of happened when we pressed the button.
So everyone has Proctorio is what I'm getting at. That's what I want to know.
I think so.
Okay, because I mean, we need it for this ATI test. That's why I'm asking. So I made you guys a practice quiz to do, and you could do it on your own time whenever you have a second. I sent it to you in email, and it's one that's I made off of ATI. So I think it's 50 questions, and I put it in review mode so that you could see rationales and stuff. So I would definitely do that. And then some other things you can do to get prepared for the ATI proctor. Take your ATI book and flip through that and look at things in those chapters that you think maybe you don't know as well and try and focus on those a little bit because you know the ATI book's a lot thinner than our regular book, so maybe that would help you kind of narrow things down a little bit. Also, let me show you a couple other things you could do. See if I can pull it up here. Okay, when you're on ATI, there is Learning System RN 3.0, and I think there's also a 2.0. So if you do that, if you go in there and they have the practice and final quizzes, you can do some OB questions that way as well. See if this will connect here. I just want you to take this proctor's test seriously and just really try to do well because you do so much better in the class if you do well on these proctored tests. So just really try and take it seriously. Let's see if I can find this. All right, nursing care of children. This is all med-surg, maternal newborn right here. So they have 1 or 2. So you could, they have, multiple groups of questions that you could do. This is under the practice quizzes. So like when you do this, This would be, let me see what this looks like. All figures. Anyway, it's something like 30 or 40 questions. It's not as big. But if you do the final one, like if you choose that, then it's going to be a little bit longer. So there's some extra questions for you to do. And then another thing you could do, if you let's see if I can share this. If you go onto Nurse Labs and go to exams, so this is just nurselabs.com. You go to exams. This is like super long, but if you flip down through here, so they have a bunch of like NCLEX kind of practice questions on here, but they also break them down into different groups of things. So they should have OB questions on here as well. Let me see if they do. Maternal child right here. So here's actual, things that you could look at as well. So I would like focus on probably these obstetric ones right here. So that would be another thing you could do to do some practice questions. So just really, try to work hard on looking at that stuff this week and making sure that you feel a little bit more comfortable about the material. I get it. It's like, it feels like it's been like kind of a rushed so many weeks with all of this. So, just do the best you can. That's all we ask. Okay, so let's see if we can get going here with our stuff. So we're going to start with this chapter 15. So just like that other chapter we went through, there was a specific chapter that talked about, changes in the mother after she had her baby, like things to watch for. So now we're looking at the baby more so in this chapter. So, focus of care during this time after the baby is born is on maintaining the baby's body heat, maintaining respiratory function, decreasing the risk of infection, assisting the parents in providing appropriate nutrition and hydration for the baby, and then also assisting parents in learning to care for their newborn. So that's our big goals in this chapter here. So believe it or not, babies go through a lot of different changes with their body too, as they're just kind of getting acclimated to their new world outside of their mother's body. So some of the things that we're going to focus on during the first 28 days of life, that is what they call the neonatal period. So you start getting all of these changes that happen once the umbilical cord is cut and the baby takes his first breath. So kind of when they take the baby out, the change is initiated by compression of the thorax. So this forces amniotic fluid from the lungs and it causes the lungs to expand because you want to see that baby breathing when it comes out. So then you have an increase in alveolar oxygen concentration and vasodilation of the pulmonary vessels. So just that, compression of the thorax kind of helps, get things moving. Also, sensory changes help get them started with their breathing as well. So things like exposure to this different temperature now, the sounds, the lights, just touch to that baby, all of that kind of gets them going as well. So the presence of surfactant, which is a phospholipid, within the alveoli assists with the establishment of functional residual capacity. All right, so there's two factors that negatively affect the transition to extrauterine respirations. So if someone doesn't have a lot of surfactant, if they have a decreased surfactant level, typically that's going to be because they have immature lungs and maybe they're a premature baby. That's going to be a negative factor. Another thing is persistent hypoxia and acidosis, because this is going to lead to constriction of the pulmonary arteries. Now, when babies are born, about 10% of neonates require some degree of assistance with respirations at the time of delivery, and about 1% require extensive resuscitation. So thank God you're not constantly trying to resuscitate everyone that comes out, Scary. Okay, so then this gets into some respiratory and circulatory changes that happen. Um, so we also, we want to make sure that we are aware if this baby is having trouble breathing. So, think about when you're assessing an adult. When you're assessing an adult and you know that they have trouble breathing, usually it's going to be because they're breathing really fast. They just, they look like they're using all of their accessory muscles, that kind of thing. So it's going to be kind of the same here. So with the baby, if they're in respiratory distress, you're going to see things like, their coloring is going to be bad. They're going to have cyanosis. You could see apnea. They might be breathing really fast, so that tachypnea. You could see retractions of the chest wall, grunting, flaring of the nostrils, and maybe even hypotonia. So hypotonia just means like their muscle tone is really bad. Like it's just like hardly anything is there. All right, when we talk about some of the circulatory changes that happen, there's three main fetal circulatory structures that undergo changes. So they have the ductus venosus, the foramen ovale, and the ductus arteriosus. So the ductus venosus, the first one, this connects the umbilical vein to the inferior vena cava. So this closes by day 3 of life and becomes a ligament. Blood through the umbilical vein is stopped once the cord is clamped. So that's kind of what that is. So that actually does, undergo a change pretty quickly after the baby is born. Then the foramen ovale. This is the opening between the right and left atrium, and it closes when the left atrial pressure is higher than the right atrial pressure. So significant hypoxia can cause reopening of this. So if someone is really having a hard time breathing, that could cause that to happen. Then the last one, the ductus arteriosus. This connects the pulmonary artery with the descending aorta and usually closes within 15 hours after birth. So you can see, there's a lot of things that happen pretty quickly after the baby is born. All right, so one of our biggest concerns when a baby is born is their temperature. So this thermoregulation. So inside the womb, the fetus is surrounded by amniotic fluid, and that kind of helps maintain a fairly constant temperature. So once they come out, they don't have all of that fluid around them. They're naked, they are wet. They just, it's a big change. It's kind of a shock to their system when they come out. So the infant has a delayed response to temperature changes in their new environment. So they need to be in a neutral thermal environment to support their, transition, so they don't get what we call cold stress. So typically, how they have those little incubator things that they stick them in that are warm to kind of help warm them up. And plus you swaddle them in, blankets and stuff and try and keep them as warm as possible. So let's talk about a couple of ways that you can lose heat. So just, I'm sure in the past, like in some of your science classes, you'll remember these terms. So like you can have evaporation, conduction, convection, and radiation that happens to help you lose some of your heat in your body. So like, conduction, so this is transfer of heat from your body to a cool surface by contact. So like if I, take the baby over to the scale, maybe the scale is really cold. So you put the baby on the scale and maybe some of their heat gets lost to the scale. Um, Convection is loss of heat from the body to the air. So yeah, maybe if you don't cover them up quick enough, maybe they lose some heat that way. And then radiation is transfer of heat from the neonate to cooler objects that are not in direct contact with the baby. So that could happen as well. So we really want to keep them from getting this cold stress. So what happens is when they get the cold stress, neonates respond to cold by increasing their metabolic rate. They increase their muscle activity. They have peripheral vascular constriction. And then metabolism of brown fat. So this term cold stress, so this is a term that describes excessive heat loss that leads to hypothermia. So when infants have this, they can develop other bad things. So they can get hypoglycemia, they can get metabolic acidosis, they can go into respiratory distress, they can have increased indirect bilirubin, they can have weight loss, you name it. There's a ton of things. There's like a huge list of them. So we try to keep them from getting this. So some things that would make them at risk for getting cold stress. People that are premature, so babies that are born too early. Small for gestational age, so if you're really tiny compared to other babies your age, that would make you more at risk. Prolonged resuscitation efforts. So if people that are taking care of you are trying to revive you for a while, that's going to be a problem. If you have any kind of neurologic, endocrine, or cardiopulmonary problems, that's going to put you at risk. So some of the things that we would see going along with cold stress, like signs and symptoms that would go with that. So your temperature is going to be 36.5 degrees Celsius or 97.7 degrees Fahrenheit or lower. Your skin is going to be really cool to the touch. You're going to be lethargic. You may have tachypnea, grunting, hypoglycemia, hypotonia. You may look really pale. You could look jittery. And babies like this usually have a weak suck. So like if they're trying to suck on something, they don't do very well with it. So some of the things that we try to do to help with this cold stress to, prevent it or make it not so bad. When they come out, babies are wet and full of all of this junk when they come out. So you try to dry the neonate thoroughly after birth. So get all that junk off of them, dry them really good. And then you swaddle them in warm blankets. And then you put a hat on their head. So usually one of those little caps to decrease heat loss through radiation and convection. And then you want to do skin to skin contact with the mother, because that kind of helps, regulate their temperature. And then, of course, we have those radiant warmers that we can put them in if we have to. Now, we want to delay the initial bath until their temperature is under control. So if this kid is still trying to get their temperature regulated, it's not a good idea to do the bath because that's going to make it worse. So you just put off that bath until that is, something that's already taken care of. Okay, so on this slide, it also talks about something called brown fat. And I think Dr. Silva mentioned this too when she was here talking with us. So brown fat is a highly dense vascular adipose tissue. So typically full-term infants possess a lot of this. And then if you're preterm, if you were born early, you don't have as much of it. And of course, adults don't have it at all anymore. So you see a lot of this around the neck, the thorax, like under the armpits, the axillary area, around your adrenal glands and your kidneys. So if you have a lot of this brown fat, it helps you it helps you thermoregulate a little bit better. So that's why we try and get people to, carry their babies full term because, they're going to have a little bit more protection. Okay. So this is talking about some other physical changes that babies might undergo. So with metabolic, they specifically mention hypoglycemia. So hypoglycemia is kind of a big deal. So if a baby is going to have this, typically it's because they had a mother who was diabetic during pregnancy. So maybe gestational diabetes or something, or maybe this mother already was type 2 diabetic or something. So risk factors for this, again, would be that. And then also babies that weigh more than 4,000 grams, so typically bigger babies, post-term neonates, preterm neonates, small for gestational age, they would be at risk. Anyone who has hypothermia, respiratory distress, and then even people who have birth trauma. So if a baby comes out and they have some type of trauma to them, sometimes they're at risk for this as well. So just like with adults, when you think about hypoglycemia, with babies, they would look kind of similar. So like, how adults can be jittery a little bit when they have a low blood sugar? Same with babies. They could be really lethargic, maybe hard to wake up or something. Same with babies, they can be lethargic. They can be real irritable, which that would be another thing adults can do as well. And then we also talked about hypotonia. That's something specific to babies. And then temperature instability. So all of that kind of goes hand in hand. So things that we would do if we suspected a low blood sugar for this baby. So we would want to maintain a neutral thermal environment to prevent cold stress, because we see that that kind of goes hand in hand with this. So we want to make sure that we're keeping them warm. And then we want to assist the woman to breastfeed or formula feed the infant. And if that's not working, then we're going to give an IV infusion of dextrose, or we could do a buccal dose of 40% dextrose gel when hypoglycemia persists. So that's kind of how we're going to treat that. So with our hepatic system, so after birth, the neonate experiences a decrease in vitamin K because they're used to getting all of this vitamin K from the mother. So once that placenta, is clamped off, they don't have that anymore. So they have a decrease in that. And vitamin K helps us with our clotting factors. So this person is going to be at risk for delayed clotting and hemorrhage because of this decrease in vitamin K. So a vitamin K injection is going to be given as prophylaxis after they're born. And obviously we don't do it right initially the minute they come out, but we do it pretty soon after they're born. All right, with the GI system. So in the book, when it talks about the GI system, it goes through all the different types of stools that you could see. But the one I wanted to point out the most is that meconium stool, because that's different than anything you've ever seen. So meconium stool is the first stool that's eliminated by the neonate, It's really sticky, it's thick, brown or black, and odorous. Um, it is usually passed in about 24 to 48 hours. So typically you'll see that pretty, early on. So, and then the book also said it's not uncommon for a neonate to pass 4 to 8 stools a day. Um, Really, you don't see a whole big problem with constipation that early on. Constipation usually does not occur in breastfed infants, but it can occur in bottle-fed infants if formula is not properly diluted. So you have to make sure that you educate parents about how to do that right. So with the renal system, so the baby actually undergoes a diuresis and like a little bit of a dehydration that goes on. So full-term neonates excrete about 15 to 60 milliliters of urine a day for the first few days of life, but then it actually increases. So the urine output increases to 250 to 400 milliliters by the end of the first month of life. So typically, you know how you go back for a follow-up appointment after you have your baby. So the baby usually loses about 5 to 10% of their birth weight during the first week of life because of this diuresis that they undergo. So you're all thinking that the baby is going to be gaining weight as you keep going, but sometimes they actually will lose some. All right, and then with the immune system, the baby has an immature immune system. So at first, they were relying on the mother because they had the placenta hooked to them, right? So they were getting, some of their immunity from their mother. So we call that natural passive immunity. So anything that maybe the mother had been exposed to and, had antibodies for, the baby would have that. And so even after the placenta is not hooked to them anymore, they will still have some protection from the mother for, a couple of months probably. And then they start having to, get their own immune system going. So neonates are first exposed to organisms from the maternal genital tract during the birthing process. So generally they aren't exposed to anything until they start to come out. And so they have to start trying to, fight off some of those things on their own. And some of the things that they might be exposed to would be something like that group B strep. And then sometimes people will have E. coli in their genital tract and everything. So there's, a few different things they might be exposed to. So have you guys heard of group B strep?
Yes.
So the mother gets tested for that at a certain point, and usually it's in the third trimester. And then once you know if she has it or not, then when she has the baby, they actually have to give you antibiotics to, help protect the baby as the baby is born. So unfortunately, I had that. It was not fun. I had to get penicillin. Okay, which of the following is a protective tissue that assists in thermal regulation of the neonate? It is that brown fat. Okay, so then this gets into a little bit about the newborn assessment. So the neonatal assessment should be done within 2 hours after birth. This initial assessment provides the baseline data for that baby. So it's just like, if you were taking care of an adult for the first time, you want to get that assessment done so you know what they're like when you first get them. So that if there's a change, you'll be able to see. So this is first talking about the general survey. So the general survey is going to be done when the baby is quiet. So you want to observe their respiratory pattern and their respirations. You want to observe their posture. You want to assess their skin color to see if they had any problems from birth trauma, or see if they have any birthmarks or anything unusual like that. You want to observe for the level of alertness and activity. And then also assess muscle tone and posture. So that's all, general survey where you're just kind of looking and you're not really touching them a whole lot. So the physical assessment is going to be like a head to toe. So you start with the head, end with the feet, and it includes assessing reflexes that are unique to neonates. So this chapter in the book is pretty long. It's a big one, and it has this huge amounts of charts in the middle of it. I would use those charts because there's a lot of important things in this chapter. So especially there's page 459, there's this big table 15-4 that talks about some common newborn characteristics. So we're going to talk about those for a second. So I didn't write every one of them down, but I have quite a few written down, and you can see the rest, in that table. So one of the things that you might see that's common to a newborn is something called acrocyanosis. And this is where you see their hands and their feet are blue in response to the cold environment. And you remember Dr. Silva was saying that's really a common thing that you see a lot. Because when you do the APGAR, she was saying it's pretty uncommon to see like a really perfect APGAR because you'll see that quite often. Another thing is Mongolian spots. So Mongolian spots are flat, bluish, or discolored areas on the lower back and buttocks. A lot of times people will mistake those for bruising or something, and they're not that. They're just, it's a normal finding that you would see in the newborn. I believe they go away over time, so I don't think you have those for the rest of your life. Then there's something called milia, and this is kind of common in newborns. And I remember back when I did my OB rotation, I remember seeing this on a lot of babies. So milia is white papules on the face, more frequently seen on the bridge of the nose or on the chin. And they have a good picture of it in the book where it shows, kind of what they look like. There's another thing called lanugo. So lanugo is fine downy hair that develops after 16 weeks gestation. And the amount of it will decrease as the fetus gets older. And it's often seen on the back, the shoulders, and the forehead. Then this one is called vernix caseosa. So vernix caseosa is a protective substance that's secreted from the sebaceous glands, and it covers the fetus during pregnancy, and it looks like a whitish, cheesy looking substance. And a lot of times you'll see it like under their armpits and in the genital areas and stuff. You'll see it in the cracks of their skin. And then of course, jaundice is another thing that you could see with kids. So yellow coloring of the skin, first you would see it in their face, and then it extends to the trunk of their body and to the rest of their body. So those are all some common things that you might see. Then when they talk about the newborn reflexes, these are on page 463 in your book. And I'm going to mention quite a few of them. I'm not going to explain every one because you could look and see what each one of them are. And I know for a fact on your next test, you have probably one or two of them on there. So you probably definitely need to look at that in the book. So there is a Moro reflex, a startle reflex, a tonic neck reflex. There's the rooting reflex, the sucking reflex, the palmar grasp reflex, the plantar grasp, the Babinski, and the stepping or dancing reflex. So that thing in the book is really good. It shows you an example of each one and how you test for that. So it's pretty good. So I would definitely take a look at that. All right, another part of the newborn assessment is the gestational assessment. So you do these different scales to try and figure out how mature this baby is, because you know how we do the estimated date of delivery in the beginning. Well, sometimes you're not quite right. So after the baby is born, they do these other exams to try and like pinpoint how mature this baby is. So there's something called the Dubowitz neurologic exam and the Ballard scale of physical and neuromuscular maturity. So those are some of the ones that you would do. And it assists in predicting potential problems and establishing a plan of care if you do see a problem. And there's examples of these on page 466 in your book. And then the pain assessment is another thing that you would do. So as you can imagine, it's really difficult to try and see if an infant is in pain, you know, because you can't really ask them because they can't talk to you. So, and it used to be like years ago, they didn't really even think about this with newborns, but you know, kind of like around the 90s, that's when they started to really be like, hey, everyone, you know, gets in pain. We need to figure out how to assess this better. So now it's part of a nursing, you know, your nursing care with your infant. It's part of your assessment. So you use pain tools. So what they do is they look at things like how much this infant arouses, so the state of arousal, the cry, the motor activity, the respiratory pattern, and the facial expressions. And so you would look at all of those things and kind of rate them to see how much pain they might be in. And some of the examples of scales that they use, there's one called the PIP, the PIPP. It's the Premature Infant Pain Profile. And then there's another one called the NIPS. It's Neonatal Infant Pain Scale. So again, you know, those are some things that you would take a look at. They also do what they call a behavioral assessment. So you see how this mentions periods of reactivity. So when an infant is born, they kind of act differently over a certain period of time. So that's what they're talking about here, this periods of reactivity. So there's three periods that they talk about specifically. The first one is the initial period. So this occurs in the first 15 to 30 minutes after birth. So during this, the respirations are irregular and rapid. The heart rate is rapid. The neonate can experience momentary grunting and flaring and retractions. And they can have brief periods of apnea and brief periods of cyanosis. So as you can imagine, you know, as the neonate comes out, it's just kind of a big shock to get into a different type of environment. So that's why they're having these crazy reactions, right? And then the second period would be the period of relative inactivity. So this is about 30 minutes after birth, and it lasts about 2 hours. So the infant goes into a deep sleep state and becomes almost like unresponsive to external stimuli. So it's kind of funny because I remember when my kids were born. So, you know, they come out, they're flipping out, they're crying, you know, they stick them on your chest and you're holding them. And you look at them and their eyes are wide open. They're super alert at first. But then when they go into that period of relative inactivity, it's right. They just totally like sleep forever. And it's like, you know, they aren't as alert. It's just different. So then the third thing would be the second period of reactivity, and this is 2 to 8 hours. So this is where the baby vacillates between being alert and being quiet. So they'll have periods of increased respirations and heart rate in response to stimuli. And then they'll also have times where they're real quiet and calm. So this is a great time to initiate breastfeeding. So that's typically when they start to do that at first. So then they talk about the Brazelton scale. So what this is, it's a neonatal behavioral assessment scale. So correct, there's all these different scales and things we're looking at, right? So with this one, they're looking at habituation. So what this means is they're trying to see if there's decreased sensitivity to repeated stimulus. Another thing that they look at with this is orientation. So orientation means it's the ability of the neonate to focus on visual or auditory stimuli. And then motor maturity. So this is the ability of the neonate to control and coordinate motor activity. They also look at self-quieting ability. So this is the ability of the neonate to quiet and comfort themselves. And then they also look at social behaviors. So the ability of the neonate to respond to cuddling and holding. And it's sad, but if you ever get a chance to work with babies and you see babies who are born to mothers who have done drugs, these babies don't have the ability to do that. So they can't respond to any kind of cuddling and holding. They just are like inconsolable. Okay, so then this gets into some of the things we do to care for this baby after birth. Okay, so when the baby first comes out, we are going to do an APGAR score. So they do it at 1 minute and they do it at 5 minutes. We also do a set of vital signs. So we do this at 30 minutes after birth, 1 hour after birth, and then hourly for the remainder of the recovery period. We also do a weight and we measure how long this infant is. We are going to inspect the clamped umbilical cord for the number of vessels and if there's bleeding. So I know, pretty much every hospital is a little bit different with like if you get transferred from one place or another, or if you stay in the same place the whole time during your birth. So I had my babies at Summa, and this was a while ago, so it's different now. I'm sure they do it differently. But when I had my babies, I was on the L&D floor and they recovered me a little bit afterwards, but I felt like they pushed me out of there super quick. I didn't have a chance to do anything. So I guess that would be the end of my recovery period when they pushed me out of the labor and delivery unit and put me on the other floor. So anyway, before you take the baby away from the mother or do anything with the baby, you always want to place ID bands on the mom and the dad, and then on the baby as well, because you need to have those identifying things so that nothing happens to that baby if they're not right with the parents. So we're also going to complete that gestational age assessment that we talked about a few slides ago. We're going to get a blood glucose on those at risk for hypoglycemia. So if this was a baby that was, low gestational weight or something like that, maybe you would get it. And then I don't know if you guys realize this, but something that they do for every baby when they're born is they put erythromycin ointment on their eyes. And so this is pretty soon after they're born. So they do this, it's like a prophylactic thing to help prevent eye infections from STDs, believe it or not. So it's like gonorrhea and chlamydia, I believe, that they're trying to protect them from. Another thing, how we were talking about the vitamin K. So typically they're going to give them that vitamin K shot, and it's an IM shot. They give that within 6 hours of birth. So that's something that we would do kind of soon. And then we also are going to notify the baby's pediatrician that they, the date and time that they were born and any kind of unusual assessment findings we might see. Okay, some other things that we're going to do. We're going to complete a neonatal assessment once a shift with this baby. We're going to prevent infant abduction because, believe it or not, that's something that's a big worry in some places. So we have like security tags that you might put around the baby's ankle or something that would trigger an alarm system if they're taken out of the unit that they're supposed to be on. You also take a footprint and a picture of the infant for ID purposes. And then some other things we're going to be concerned about doing is we're going to help the parents with feeding. So if it's the first time that the mother is breastfeeding or something, you're going to assist with that and tell them some tips on what to do. And we want to promote parent and infant attachment as much as possible during this time. And then, this on the slide here talks about skincare. So with babies, their skin is kind of sensitive and they are at risk for a lot of things to happen. So like, especially, when you start putting diapers and things on them, they're going to be at risk for diaper rash all the time. So you're going to really watch closely for that and try to keep them as dry as possible. They could have, some areas on their body from, birth trauma that you might have to watch. Maybe they have abrasions or bruising or something. They could be at risk for pressure issues. So I remember my one niece when she was born. They constantly, they always tell you to put your babies on their back, so they always would lay her on her back, and then she had a flat area on the back of her head because of that. So then they ended up having to make her wear this like helmet thing to try and um, fix that flat area on her head. So, that's, something that could be a concern as well. And then with immunizations, they might do like a hepatitis B while they're there in the hospital. So, you know how hepatitis B is a 3-step thing. So they would give the first one while they're there in the hospital. And usually this is an IM shot that's in the vastus lateralis muscle. So back a few weeks ago, I think we mentioned PKU a little bit. So this is an error in metabolism that can lead to a buildup of phenylpyruvic and phenolactic acid. So the buildup of these can cause permanent brain damage and death. So you try to prevent this by early detection and dietary management. So this is something that they would screen for at birth. So this PKU. And they do when they're screening for things, they do like a heel stick. So the heel stick, is going to collect enough blood for checking for these different things. So again, like if this person had a low blood sugar problem or something, you could check it that way through this heel stick. Another thing that we're going to screen for is hearing. So hearing screening is done because hearing loss is a common genetic abnormality. So in the book, it said 1.6 out of 1,000 infants have an abnormality in hearing. So they say early detection provides opportunities to seek interventions that will help foster their language development. So that's kind of why we do that. So with medications, again, that erythromycin is just to be given prophylactically to help prevent any kind of gonorrhea or chlamydial infection of the eye. The vitamin K injection is given to help with blood clotting. And of course, the hepatitis B immunization before discharge, like we were just talking about, because hepatitis B can be spread through contact of blood, with an infected person, and then it can cause inflammation of the liver. So we want to try to prevent that. With oxygen therapy, um, generally we're not giving infants oxygen unless they absolutely need it. So some of the reasons why you might be giving it would be if their heart rate is below 100, if they have cyanosis, or if they have apnea. So they say before you give it, you want to check the airway and apply suction if indicated, and stimulate the neonate by rubbing his or her back. And maybe that might help a little bit with the problem. Okay, so with circumcision, this is an elective procedure, so not everyone has to have this, but quite a few people do get this done. So there's different things that they do in different phases of the procedure. So you see how they have pre, intra, and post-op nursing actions. So with the pre, so before you would do this procedure, you don't want this infant eating or drinking anything 2 to 3 hours before. And it's kind of stupid, but they say they're worried about vomiting during the procedure and that they could aspirate. You always need a consent form signed from the parents. And then typically the physician will do some type of medicine beforehand to try and help prevent a lot of pain during the procedure. So acetaminophen sometimes is given 1 hour before for pain management. And I have seen people do that EMLA cream as well. So EMLA cream can be put on to the skin, at the area that they're going to work, and that kind of helps numb up the area a little bit. So during the procedure, the baby's positioned on this plastic board. Sometimes they give them a pacifier during this that's dipped in some kind of sugar like sucrose to try and help keep them calm. And then after they do the procedure and do what they need to do, when they're done, they're going to put petroleum impregnated gauze wrapped around the penis at the end. And then after the procedure, so post, you're supposed to assess the penis every 15 minutes for signs of bleeding. You can give acetaminophen again. It can be given every 4 to 6 hours if you think they need it. And you're worried about signs of infection, so you're watching for that. You're worried about bleeding, and then you're worried about them being able to void. You want to see that they're voiding okay after this procedure. So those are some of the big things to watch for. And then on here, this also talks about contraindications. So infants that probably shouldn't get this done would be preterm neonates, neonates with genitourinary defects, neonates at risk for bleeding problems, neonates with compromising disorders like respiratory distress syndrome. So those would be some things you would probably hold off on doing this for. Okay, this says the neonate is given which of the following to facilitate blood coagulation? We said vitamin K. All right, so as you can see, there's a lot of different things that happen with babies when they come out, a lot of changes that they undergo, and a lot of different things that we have to, pay attention to after they're born. So this is kind of an important chapter, so make sure you pay good attention to some of the things they show you in the book. Okay, let me get to the other one real quick. Okay, this next chapter, chapter 16, has to do with some discharge planning and teaching things we would do with parents. So, let's see if we can get into that a little bit. So, they say caring for a newborn and raising a child to adulthood are some of the most important roles parents will assume in their lifetime. So, discharge planning and teaching is going to begin during pregnancy, believe it or not, even before the baby is born. And then when couples are encouraged to read about their infant and, do infant care classes and all that kind of stuff. So we talk about stuff way back then, even. So throughout the postpartum hospital stay, teaching is provided in short sessions to the woman and her partner and to family and caregivers. And you try to do short sessions so you don't overwhelm them. A written copy of key points of infant care is given to the parents at discharge, which I remember when I had my first kid, I was really happy about that because I'm like, I don't remember anything they told me. So I liked having something written because then I could refer back to that if I had a question. A follow-up appointment is scheduled typically pretty soon after the baby is discharged and you're discharged. Um, and it's not that your physician wants to see you very quickly, but they usually want to see the baby pretty quickly after they get discharged. So maybe about 48 to 72 hours, you're going to take the baby back in to get looked at. Okay, so when we talk about discharge teaching, there's 5 rights to teaching. So they talk about the right time. So this means, hey, is our learner ready and motivated to learn? So if they are not willing to learn or they're not giving you good attention at the time when you're trying to teach about something, it's not the time to be doing it. Because you have to make sure that they're paying attention to you and taking in what you're saying. Um, Another right is the right context. So this means, is the environment right for teaching? So we always talk about that, like with adults, when we teach adults, we say, is this person comfortable? Are they in pain? Is there a lot of noise around, or is it nice and quiet in the room? Like, think about those types of things. So you want the environment to be conducive to learning. Um, the right goal is the third one. So is the learner involved in planning the objectives? So what does the learner want to learn? So make sure they're involved with that. And then the right content. So is the content appropriate for the client's needs? And then the fifth one is the right method. So do teaching strategies fit the learning style of the client? So that's kind of what we're looking at there. So typically when we do discharge planning, there's certain standard written instructions that we give everyone. And then there's also some more tailored discharge plans. So like, say, for example, I'm someone who had a C-section, then I have specific instructions for a C-section patient compared to someone who had a vaginal birth. So you may have more like specific things to tell someone like that. And then again, we talked about follow-up appointments and how important that is. All right, so then with breastfeeding. So breastfeeding is super important, and we try to get everyone to do this at least for a little bit if they can. So there's some, good benefits to this, and I'm going to talk about some of those. So when we talk about the infant, benefits to the infant, um, infants who breastfeed are going to have a decreased risk for gastroenteritis. They're going to have decreased hospitalizations due to RSV. They're going to have decreased incidence of otitis media. And there's like a huge list of things that the book lists. I just listed a few there. But there's quite a few things to benefit for the infant. And then over long term, benefits are going to be decreased risk of asthma, decreased risk of obesity, decreased risk of sleep disorders, and there's a bunch more. So there's quite a few benefits for the baby themselves. Then for the mother, when we talk about that, short-term benefits for her would be it's going to help decrease blood loss. It's going to decrease the risk of infection. The mother can lose more weight if she breastfeeds for 3 months or longer. So that's kind of a plus for a lot of people. And then for long-term things for the mother, she's going to have a decreased risk for diabetes, metabolic syndrome, ovarian and breast cancer. Breastfeeding also will enhance maternal fetal attachment, and it also decreases the risk of postpartum depression. So those are all some real, good benefits for that. So believe it or not, there are some reasons why you should not breastfeed. So some of the reasons for that would be certain, disorders that you might have. So if you have TB, TB is an airborne, thing that you could pass to people. So you would not want to breastfeed if you had TB. You want people to be staying away from you if that's the case. So if it's active or if it's untreated, that's when you would not want to breastfeed. HIV is another thing. So HIV can be transmitted to the baby in the breast milk. So that's why we don't want to breastfeed if we have HIV. Galactosemia is another condition they say to not breastfeed if you have that. And then if you are sick, I don't know how often this is. I'm sure occasionally you'll see a mother who may have other medical conditions wrong with her. Maybe she has cancer and she had a baby. So if she has to do chemotherapy, she probably shouldn't be breastfeeding. If they have anything like radioactive that they're taking, not a good idea. That's going to transmit to the baby. And then also if they're, currently doing street drugs, because that's going to transmit as well. All right, so when we talk about milk, so milk production is a little bit different. So there's 3 stages of how this develops. So I'm going to try and talk about that for a second. So one of the first stages is where you get that colostrum. So colostrum starts producing in the 2nd trimester. So it's kind of early on in your pregnancy. It's thick yellowish breast fluid, and it has increased levels of protein and decreased levels of fats, carbs, and calories. So it's really good for the baby. And it contains high levels of immunoglobulins, and specifically G and A. So that's in stage 1 of milk production. Stage 2 is where you have transitional milk. So this is where the milk has colostrum mixed in with it. So colostrum and milk are mixed together. So this lasts for 6 to 13 days, and the milk changes to have decreased levels of protein, increased levels of fat, carbs, and calories now. So in stage 2, now all of that changes. So stage 3 is going to be where you get mature milk. So mature milk is composed of 20% solids and 80% water. So human milk will change to meet the needs of the infant. So for example, milk produced for a preterm infant contains twice the amount of protein than milk produced to mothers of full-term infants. So I thought that was kind of interesting that it actually changes to help the baby. All right, so you can see, as you're in those different stages, how the milk changes, and it benefits the baby definitely. Okay, so then this talks about the letdown reflex. So what this is milk ejection that results in milk being ejected into and through the lactobacillus duct system. So letdown occurs multiple times during each feeding. It can be inhibited by stress, anxiety, pain, and it can be stimulated by hearing an infant crying. So, like, for instance, you could just be, after you have your baby, you could just be around someone else's baby, and all of a sudden it starts crying, and all of a sudden you'll look down and you'll see wet marks right here on your boobs, because it just, causes this letdown reflex to start happening. Um, so, those things that I said about inhibiting it. So, when people are trying to breastfeed, they have a hard time a lot of the time because maybe they're under stress or they're having pain or something. And so, those are some of the things that can cause you to have trouble. So, as a nurse, we have to try and help, get to the bottom of some of those reasons why they might be having trouble to help with that. Let's go on here. Okay, which of the following is a contraindication for breastfeeding? So it would be tuberculosis. So active or latent tuberculosis in the mother. Okay, and then when we're talking about breastfeeding again, so there's different cues that your baby will give you to show you that they're ready to eat. So hunger cues. So opening of the mouth in response to tactile stimulation. So like maybe you go like this and they start opening their mouth or something. Hand to mouth movement. So that's another one. If they're in a quiet, alert state, rooting, sucking sounds or movement, sucking of fingers or their hand. So those are some hunger cues to show you that they're ready to eat. And then when it talks about the process of latching on, when you're breastfeeding, this is kind of tricky. So they say in the book that the woman brings the newborn to her breast when the mouth is open wide. To encourage the newborn to open wide, you take advantage of the rooting reflex by touching the newborn's chin to the breast, and this signals the newborn to open their mouth. So that latching on then is going to refer to the newborn's ability to grasp the breast and to effectively suckle. So they want that nipple way back into the back of their mouth, and they want to have a good seal, around their mouth, around the breast. So when this talks about positioning, there's a lot of different ways that you can position yourself when you're breastfeeding. A lot of people do different holds. Some people do the football hold, and there's different ways you can do stuff. So whatever's more comfortable is what we would want the mother to do. And then burping. So we want this person to burp their baby kind of frequently. So you might have to do it in the middle of a feeding. You might have to do it at the end of a feeding. So typically, it's going to make the baby feel better and not have all of that air build up in there. Okay, so here's where it starts talking about breastfeeding concerns. So again, like we were just talking about a few minutes ago, anxiety can play a part here. So if you're having a lot of anxiety, it can make you not have that letdown of your milk, and then you could be having issues trying to have this happen. So it also talks about nutrition and medications here. So the mother wants to make sure she's having really good nutrition when she's breastfeeding, because the baby's getting their nutrients from the mother, from the mother's milk. So you want to eat things that are going to agree with your baby. And then with medications, most medications are pretty safe to take while breastfeeding, but you always want to check with your doctor just to make sure. So if you're ever concerned, they would be the one to tell you yes or no. And there's certain things that aren't safe. So maybe you would have to switch to a different medication, or maybe be off of it for a while if you were going to breastfeed. Okay, and then this mentions nipple breakdown or pain. So to prevent this problem, we want to apply warm compresses to the breasts and nipples before feeding to enhance the letdown reflex. We want to begin the feeding session on the less sore breast. So if you have one that's really sore, go on the other side. You want to wash your breasts with water only because soap and alcohol can dry the nipples. And then you want to contact the provider if experiencing dryness or cracked or bleeding nipples, because then you're going to be worried that you might have an infection. So that's something that you definitely need to keep an eye on. So high levels of anxiety and discomfort can interfere with successful breastfeeding. So to decrease anxiety, we want to be as calm and patient with our patient who is the mother as needed. We want to provide easy to understand breastfeeding information over several teaching sessions to not overwhelm the mother with too much information. And then we want to teach breathing and relaxation techniques as well, because that might help, with them having that problem. All right, so then this mentions formula feeding. So there are different pros and cons to that as well. So some advantages of formula feeding would be that either parent can take part in it. So it's not always just the mom that has to do it, so the dad can do it. Women can go back to work without pumping if they use formula, so that's kind of nice, because although we like when people pump and still have breast milk that they use, it's difficult when you go back to work to try and stay on a schedule to do that, because you're supposed to pump every so many hours, and then sometimes your work isn't real baby friendly and stuff, and it gets to be complicated to try and do that. Also, there's a decreased frequency of feedings because babies digest formula slower than human milk. So those would be some advantages. Now, some disadvantages would be the cost, because you have to pay for formula, right? And there's some out there that aren't as bad as others. There's others that are kind of expensive, but so the cost would be an issue. Increased risk of childhood obesity from formula. Increased time to prepare formula. So not as much immunity protection as well. So those would be some disadvantages. Okay, so then this starts to talk about, kind of as the baby gets older, how you transition them to regular food and stuff. So typically we're on breast milk or formula for, until your baby's about 4 to 6 months. And they tell you to do this to reduce allergy risks, because a lot of kids have allergies, if you start them, too early on stuff. So semi-solids are started usually when the baby can sit up independently, when they can draw in their lower lip as a spoon is removed, when they indicate hunger by opening their mouth, and when they refuse food by closing their mouth and turning away. So typically what we would first start them on would be cereal, and then eventually you start them on fruit and vegetables and other, baby foods. Okay, so then this gets into a little bit of newborn care. So with the cord, with the umbilical cord. So this will dry out once the cord is clamped. The clamp is removed usually in 24 hours after the birth, and 24 hours after that. So then you can look over the next few days and the cord becomes dry, hardened, and black, and then it eventually falls off. So it's really not too big of a deal with getting that cord to come off. As they still have the cord, when you're putting diapers on the baby, you want to place the diaper below the cord to facilitate it drying out, and then clean it with plain water and dry it thoroughly. Things that you would watch for would just be watch for foul smelling drainage, bleeding at the cord site, or fever because you're worried about infection. With the circumcision site, you would check for bleeding every so often, notify the healthcare provider if there's signs of infection, or if the newborn hasn't voided in the last 24 hours. That would be a big problem. Then they talk about a little bit about bathing and clothing and diapering. So with bathing, so a lot of people think they got to bathe their baby every day, which that's not really the best thing to do because you're going to dry out their skin. So maybe every other day or every couple days would be better for the baby at first until they get a little bit older. With clothing, they talk about not overdressing the baby at bedtime. So you're worried the baby's going to be cold, so you put all this stuff on them and blankets over top of them and everything. And they say if you overdress at bedtime, the baby can overheat and it may make them at increased risk for sudden infant death syndrome. So you have to be careful with that. And then every time you change their diaper, you should be checking to see if they're having any skin issues. So try to keep them as dry as possible. So change their diaper frequently, check them every so often, and watch for that diaper rash so you can prevent that. Some things that you can use would be stuff with vitamin E in it. Um, so there's a lot of different diaper rash creams out there. I used to use Pink Salve a lot. I used to really like that. That helped a ton. All right, and then this mentions colic. So colic is just when you have a really fussy baby. So it's a healthy infant who cries for at least 3 hours or more for 3 days a week or at least 3 weeks. They're considered colicky. So some of the things that you could do for a baby like this, you could give them a pacifier, you could swaddle them, you could place them in a baby bouncer, put them in a stroller, take them for a walk. Sometimes babies just like the feeling of movement. So if you can stimulate that in some way, like maybe you put them in their car seat and you sit them on top of your washing machine or something as you're standing there observing, so they don't fall off or anything. But if you put them there, they feel that movement from the washing machine, and maybe that might, you know, quiet them down and get them to relax. So there's a lot of weird things people do, but yeah, so colic can be pretty stressful for certain people. All right, so then this gets into follow-up care. So again, usually the doctor's going to want to see the baby, usually within 48 to 72 hours after discharge. Um, so some of the things they look at when they take them in for this appointment, they're going to assess their growth. So they'll weigh them and measure them. They'll see how they're doing with feeding. They'll look at their development. They'll see if they have any jaundice going on, those types of things. So my daughter, Natalie, when I had her, um, it's funny. So she had jaundice, and in the hospital, now that I look back and look at pictures, I'm like, geez, she did look really dark. And I didn't know any better, so I didn't notice, honestly. And so we took her home, and I ended up taking her back for her follow-up appointment, which I think was pretty quick. And they ended up telling us to go straight to the hospital. So I had to admit her into Children's and have her put under the lights to get rid of this jaundice. It was so stressful for me because I have all of these hormones going crazy, and I had to, spend the night with her in the hospital. It was just really crazy. So jaundice is something that definitely could be a big problem. So basically all they do is she gets put under these lights, and they put like this little, almost like a little mask over their eyes to protect their eyes, and she's put under those lights for a certain period of time, and it helps dissipate that jaundice. So it worked really well, and then she was a lot better. Okay, another thing that they mention here is this PAHT. What this stands for is pediatric abusive head trauma. So another word for this would be shaken baby syndrome. So unfortunately, this is a thing, and we do see this with certain people. So this can cause injuries that can cause death or severe brain damage. So something to really watch for when, people come in, that would be something they're going to look for. Um, and then tooth decay is another concern. So when sweetened liquids are given in bottles to infants and they're allowed to remain in the mouth for a period of time. So like I used to see people, they would put like some kind of apple juice or something in a bottle and they give it to their baby and then put them to bed for the night. And then the baby would just be sitting there with it in their mouth forever. So it's those people who are going to end up having tooth decay. So not a good idea. And then when they talk about safe sleep, so we want to always put our babies on their back because, there was a time where everyone used to put them on their stomach, and then we had all of those sudden infant death syndrome cases. So now they say put them on your back, um, keep soft objects and toys out of the crib. Like, years ago we used to have bumpers and 3 million stuffed animals and blankets and all this stuff in there. So that can cause a problem. So you always want to keep all of that out of there. And then it's not wrong to put them on their stomach occasionally. Doctors want you to do that occasionally, but they don't want the baby to be unsupervised when you're doing that. You have to watch them. And it should only be for short periods of time for like when they're playing or doing something like that. All right, and then this is talking about safety stuff. So when you think about it, there's a ton of things that can go wrong at home for safety with kids. So I remember when I was a little kid, we got these stickers at school, and it was I think it was Mr. Yuck. It was a sticker that said Mr. Yuck, and you got them and you put them on all of your cleaning products in your house. Because years ago, my mom used to keep everything under the sink, so we could get to it real easily. But if she had those Mr. Yuck stickers on there, we would know that those were something we had to stay away from, that we shouldn't mess with them. So now anymore, they tell everyone to keep everything up out of the reach of their kids and stuff so they don't get into things. Those like those pods that we use for washing our clothes, those are a big deal. So like if the kids get into those and bite into them, that could be a huge problem, right? So that's another thing. And then anything that's like really small, any small objects you want to keep out of the reach of children so they don't choke. You want to have those gates that you put all over your house so they don't go up and down the steps and fall. If you have a swimming pool or something, you want to make sure that that is monitored all the time, or you have a gate or something around that so they can't get in and out of there by themselves. There's just a ton of things to think about with safety. So that's a big deal. Then with sibling rivalry. So if you have other kids, sometimes they have a hard time accepting a new sibling. So they say to start preparing your child early. Talk about the new baby that's coming and talk about how they can be involved and keep them involved and have them help you occasionally. And just make sure you still pay attention to them so they don't feel like they're unloved. Um, with skincare, again, we talked about that a little bit ago. We said to avoid daily bathing. You avoid the use of skin ointments or perfumes or dyes or preservatives. So like if you have the choice of what kind of laundry detergent to use for your kids' stuff, you want to use stuff that's dye free because it can cause problems for their skin. And then this mentions stuff about soothing the baby and swaddling them. So there's 5 S's for soothing babies. So they mention swaddling, the side position or stomach position when supervised, shushing, swinging, and sucking. So the sucking would be like, pacifier that kind of helps soothe them sometimes. The swinging, we used to do that constantly for our kids. So we had a swing for our boys when our boys came home from the hospital. We had 2 swings, and we would put them in the swing, and they would sleep in that swing for until they got too big to be put in there, and then we put them in something else. So that movement was very soothing for them. Swaddling is just how you wrap them in the blanket. And if you wrap them nice and tight and everything, it helps them to be more comfortable and soothed. Okay, so the first follow-up visit should take place when? This is 48 to 72 hours after discharge. All right, so discharge teaching. Um, some of the things that we're going to tell people are going to be, hey, call your doctor if your infant has an increased temperature, if they refuse to eat, if they're really lethargic, if they don't cry or have a really weak cry, if they've lost their appetite and they're not interested in eating every 3 hours, etc. You know, those types of things we're going to tell them to report. All right. We got one more. Well, let's take it forever. Let me see if I can pull it up this other way. Here we go. Okay, so this last chapter is talking about high-risk neonatal nursing care. So in the first part of the chapter, they talk about infant mortality rates a little bit. Here, let me get to the right slide. So they say that infant mortality rates have gone down over the years, but there still needs to be some more improvement because in the United States, we have so many, um, you know, things at our disposal that we shouldn't really have such high rates of mortality in infants. And they say one of the primary causes of neonate complications is related to prematurity. So that's kind of a big focus in this chapter is the premature infant. Okay, so when we talk about prematurity, so they're going to say there is a difference between three types of prematurity. So there's low birth weight, which this would be less than 2,500 grams at birth. There would also be very low birth weight. This would be less than 1,500 grams at birth. And then there would be extremely low birth weight, and this is less than 1,000 grams at birth. So super small, super tiny. Let's see. All right, so when it talks about risk factors for preterm neonates, there are non-modifiable risk factors, and then there's treatable modifiable risk factors. So some non-modifiable things would be, hey, I've had, let's see, placenta previa after 22 weeks, or I have bleeding in my first trimester, or maybe I have multiple gestations, so multiple babies. So those are non-modifiable things, right? And then some examples of treatable things that are modifiable would be life stress. You know, you could try to figure that out and get your stress under control. Um, your weight, obesity, that would be another thing that you could try and control. Cigarette smoking would be another thing. Air pollution, like you could stay out of that and not be in it. So those would be some examples of modifiable things. So there's actually a big table in your book on page 507, table 17-2, that lists a bunch of those things if you want to take a look. All right. So when we talk about preterm babies then, for assessment, they are going to look way different. So our assessment findings are going to be different compared to a regular baby. So some of the things that we're going to see, their skin is going to look really different. Sometimes it looks translucent or transparent or more red. You know how we were talking about that brown fat earlier? These guys have barely any, if at all. So the subcutaneous fat is hardly there at all. Their eyelids can sometimes be fused shut. So they don't have eyes that open until about 26 to 30 weeks gestation. Their cry, if they cry at all, is going to be super weak. Their reflexes are going to be really diminished or absent. They may have apnea when they're breathing. Sometimes you could see them have a heart murmur. Their sucking is going to be real immature. So if they try to suck on anything, it's hardly going to be anything. Anemia is really common. And then also hypotension might occur. So those are some of the assessment things that you might see. So with respiratory, their lungs are often premature. So they need to give infants, if you're wanting to deliver this baby preterm for one reason or another, like say maybe the mother has really high blood pressure. So you think, okay, I can't wait any longer. I have to deliver this baby. So they're going to give corticosteroids to help try to mature this baby's lungs. So the corticosteroids they would give would be betamethasone or dexamethasone, typically those. So anyway, when kids are premature, typically they are not going to be breathing really well on their own if they have really immature lungs. So most of the time they're going to have to be put on some kind of support. So whether they're intubated and on a ventilator or maybe just on some type of form of CPAP, they're going to probably need some help for a while. So while they're on all of this, we are going to be monitoring them super close. So we got to look at all of their labs a lot. We have to, give them certain medications while they're on this to keep them calm and help heal them up, basically. So there's a ton of things that are involved with this. And then, of course, let me keep going, with cardiovascular problems. So with the cardiovascular problems, again, you could have low blood pressures, you could have low oxygen saturations and blood gases. So you're going to have to be, watching their intake and output really closely. You may have to give them fluids or restrict fluids depending on what's going on there. So these guys require quite a bit of care just because of all the different things they have going on. Then, this mentions neutral thermal environment. So again, they're going to really have a hard time controlling their temperature. So they're going to have to be in those warmers pretty much all the time. With nutrition, you're probably going to have to give them some type of like a tube feed type of a thing. So this is going to be like an NG tube basically, but really tiny that they'll put through their nose. And so you're going to have to give them that to keep them so that they're growing and doing what they need to do. You're going to want to involve the parents as much as you can. So it's very difficult on the parents during this because they can't have their baby home. They're really worried about what's happening. Their kid's hooked up to all of these different things. So it can be very stressful for them. So keep them involved as much as possible. If you can have them hold the baby, if you can get it out of the warmer occasionally and have them hold them, that does really make a big difference. So you can do that. Encourage them to maybe put pictures of family members around, even though the baby can't see it. But I mean, whatever they want to do to make them feel better, that's okay. Just encourage their involvement as much as possible and keep them up to date on whatever tests and procedures they may have coming up too. Okay, a lot of this chapter goes over different disorders that you might see. So I'm going to try and hit on some of those. So the first one is respiratory distress syndrome. So this is a life-threatening lung disorder that results from small underdeveloped alveoli and insufficient levels of pulmonary surfactant. So the incidence of this will decrease with increasing gestational age. Some of your signs and symptoms would be hypoxemia, hypercarbia, pulmonary artery vasoconstriction, metabolic acidosis, so yeah, you're pretty sick when you have this. So some of the things that we would do for like support during this time. So again, respiratory distress is going to vary based on your level of prematurity. So if you're really super premature, it's going to be a lot worse compared to if you're just a little premature. So usually that respiratory difficulty is going to begin shortly after delivery. And as they start to try and work harder and harder to breathe, that's when you see, okay, they're in distress. I need to put them on something to help support them. So typically they are going to be on a ventilator. So, or they could be on a CPAP even too, I guess. So the mechanical ventilation is used when CPAP's not effective. So I think they try to do CPAP first, but if that doesn't work good enough, then they do the ventilation. And then there's also something called ECMO that they could do. This is extracorporeal membrane oxygenation therapy. So it's basically a cardiopulmonary bypass machine that's used when the neonate does not respond to conventional ventilator therapy. So that would be kind of a last resort. So every day that this person is on mechanical ventilation, you're going to get chest x-rays to evaluate what their lungs look like. You're probably going to get lots of blood gas results, to follow along with that. This person's going to be on antibiotics, to prevent infection. So you want to constantly assess if they have a patent airway. Look for correct placement of that endotracheal tube every time you're coming in to take care of this baby. So this is listening for equal breath sounds bilaterally. Another way to assess that would be do an end-tidal carbon dioxide detector. That could tell you too if you're in the right place. What else? Also, you're going to be doing some suctioning of the airway to remove any kind of secretions that they might have that they're having a hard time getting out. Just that kind of stuff is what we're going to be doing while they're on this. Okay, the next one is bronchopulmonary dysplasia. So this is a chronic lung problem that affects babies who have been treated with mechanical ventilation and oxygen for things like respiratory distress syndrome. So neonates who are dependent on oxygen beyond 28 days of life or have been on a mechanical ventilator are at increased risk for this. So this condition will lead to decreased lung compliance and pulmonary function secondary to fibrosis, atelectasis, or increased pulmonary resistance. So they can get pulmonary edema, and it can be bad. So the prognosis for people with this is dependent on the severity of the disease and the infant's overall health status. So long-term outcomes may include prolonged hospitalization, so they may be in the hospital for a really long time. They may have to have oxygen at home when they go home. And then sometimes you could even get things like cerebral palsy, retinopathy, and hearing loss as a result of this too. So risk factors for this BPD are prematurity, oxygen toxicity, respiratory distress syndrome, intubation, lower gestational age and birth weight. Excuse me. So some of the things that you would see with this as far as like signs and symptoms, you could see hypoxia. If you're listening to their lungs, probably wheezing, rales, or rhonchi. You could see intolerance to fluids. So they could have edema, decreased urinary output, and weight gain. And then you would have a difficult time getting them off the ventilator. This person's going to be really hard to get off there. So some of the things we would do to treat this, so basically they're going to give them bronchodilators to administer, to help with bronchoconstriction, corticosteroids to reduce bronchospasm and edema, and then diuretics to get rid of some of that extra fluid that they're keeping on board. So again, with this person, some of the things that we might do as a nurse would be, not only are we monitoring them while they're on their ventilation, but we also might have to do chest physiotherapy. So remember, this includes like doing the cupping on their back, doing that, the vest that shakes them, to get rid of some of those secretions so you can suction it out easier, that kind of stuff. So that's what that is. So which of the following is the condition that affects infants who have received mechanical ventilation? That's going to be this BPD. Okay, so the next one that it talks about is patent ductus arteriosus. All right, so you're like, what the heck is that? So what this is it is something that remains open after birth. So during fetal circulation, the ductus arteriosus connects the pulmonary artery with a descending aorta, and then it shunts blood away from the lungs. So normally this is going to close within the first few hours of birth, but it can take as long as 96 hours. So the incidence of this among neonates is 1 in 2,000 live births. And usually you're going to see this more in babies with a lower gestational age and birth weight. So complications related to this are congestive heart failure, chronic lung disease, renal failure, and then also intraventricular hemorrhage. So it can be a big deal. So when someone has this, you are going to hear a heart murmur, and this is going to be heard at the upper left sternal border. This person's going to have a widened pulse pressure. So with a decreased diastolic blood pressure, they're going to have recurrent apnea. They could have tachycardia and tachypnea, increased work of breathing, and then a chest x-ray may show increased pulmonary vasculature, pulmonary edema, and mild enlargement of the heart. So what are we going to do for this? So diuretics. We also might be giving some medications like indomethacin and ibuprofen. Usually you're going to have a cardiologist involved if this is the case. And sometimes they actually have to go in and do surgery to do a surgical ligation of this to, close it up. So that's kind of the gist on that one. All right, then we have intraventricular hemorrhage. All right, so what this is so this occurs in the germinal matrix tissue surrounding the lateral ventricles of the developing brain. So this is like a brain bleed that we're talking about. This occurs in premature neonates, and sometimes it's more common in ones that have respiratory distress syndrome. In those who experience complications associated with ventilation, like maybe pneumothorax or acidosis or something. So they say there's 4 grades of intraventricular hemorrhage. There's a grade 1, which is hemorrhage in the germinal matrix. Grade 2, intraventricular hemorrhage without ventricular dilation. Grade 3, intraventricular hemorrhage with ventricular dilation, where you have clots that fill more than 50% of the ventricle. And then grade 4, extension of blood into the cerebral tissue or parenchymal involvement. So if you have someone with this, you're going to see things like sudden change in their condition. They might have bradycardia, hypotonia, metabolic acidosis. They might start going into shock. They could have a high blood sugar. And then, basic signs of bleeding that you might see. So a drop in their blood pressure, apnea, maybe seizures, full intense fontanelles, and rapid increase in head size. Oh, that would be scary. Okay, so some of the things that we do for nursing actions. So you're going to assess for changes in their vital signs and their behavior and their neurostatus. You're going to try to reduce stress to the neonate by maintaining a quiet and dark environment, and then administer fluid volume replacement slowly to minimize fluctuations in their blood pressure. Okay, so then they talk about necrotizing enterocolitis. So this is a gastrointestinal disease that affects neonates. So it causes inflammation and necrosis of the bowel, usually the proximal colon or terminal ileum. So you would get altered blood flow regulation, particularly to the intestines. You could have impaired gastrointestinal host defense when faced with stress injury to the intestinal tissue, alterations in the inflammatory response. So some causes for why someone would get this. Low body temperature, hypoxia, hypotension, stress. Patent ductus arteriosus would be another one. So for this, when people get this, this can be fatal in 10 to 30% of cases. So it's a pretty serious thing. So what we do for this. So some of the things we're going to do. We're probably going to get abdominal x-rays and, serial x-rays like daily so we can see what's going on. We're going to do blood cultures and some blood work. We're going to give them antibiotics, antihypertensives. We're going to discontinue oral feedings and make them nothing by mouth. And then we're probably going to have like an NG tube down to, do gastric decompression. So they do surgical management with this. So the surgical intervention is the removal of that necrotic bowel, and then they resect it and reattach to good tissue. And then maybe a temporary colostomy can be performed. All right, then they talk about meconium aspiration syndrome. Okay, so this is a cause of respiratory failure in a lot of term and post-term neonates. So respiratory failure can happen when that meconium, which is that stool that they can have inside the mother actually gets into their lungs and causes partial obstruction. So some of the symptoms that you might see with this would be meconium-stained amniotic fluid. So that would be really significant. Meconium visualized below the vocal cords. Greenish or yellowish discoloration of the skin, nail beds, or umbilical cord. Respiratory depression at the time of birth. Low APGAR scores. Signs of respiratory distress. Diminished air movement, all those types of things. So what are we going to do for this? So some of the stuff that we do, of course, you're going to get a chest x-ray. You're going to try and suction a lot of that stuff out if you can. A lot of times they will give the baby surfactant therapy. The surfactant therapy is going to help decrease their risk to be having to put on that ECMO machine that we talked about before. Antibiotics to treat possible pneumonia. And then for us, we're going to administer oxygen or give ventilation if we need to, monitor their blood glucose, and then monitor their temperature as well. Okay, then they talk about persistent pulmonary hypertension of the newborn. All right, so what this is normally after birth, the pulmonary vascular bed is going to relax, and it allows blood circulation to the lungs. So persistent pulmonary hypertension is going to happen when normal vasodilation and relaxation of the pulmonary vascular bed does not occur. So this is going to lead to elevated pulmonary vascular resistance and right ventricular hypertension. So risk factors for this would be hypoxia and asphyxia, low APGAR scores, respiratory distress syndrome, bacterial sepsis, hypothermia, hypoglycemia. So some of the things that you would see with this, of course, you're going to see some respiratory issues. So they're going to be slow to breathe, difficult to ventilate. They're going to have cyanosis. They're going to look like they have infiltrates on their chest x-ray. And then with cardiac stuff, you're going to see congestive heart failure symptoms with them. You might hear a heart murmur. Some other things, you could actually have some kidney damage. You could see low urine output, proteinuria. So our main goal with this is to correct the hypoxia and acidosis. So we're going to try and do that. And then, we're going to do an echocardiogram to look at their heart to see if there's any other abnormalities that maybe we're not seeing. We're going to give them oxygen and maybe put them on mechanical ventilation, give them IV fluids, probably going to give them some things like vasopressors, vasodilators, muscle relaxants, antibiotics. All right, the next thing they talk about is small for gestational age and intrauterine growth restriction. So, a small for gestational age infant is one whose weight is less than the 10th percentile for his or her gestational age. So they're really tiny. Neonates whose growth is not consistent with gestational age may be affected by intrauterine growth restriction. And this can be caused by a decrease in cell production related to chronic malnutrition. So there's two types of intrauterine growth restriction. symmetric and asymmetric. So symmetric is a generalized proportional reduction in the size of all structures and organs except for the heart and the brain, and it occurs early in pregnancy and affects general growth. Asymmetric is a disproportional reduction in the size and structures of organs, and it results from maternal or placental conditions that occur later in pregnancy and impede placental blood flow. All right, so if someone has this, if a baby has this, labor intolerance related to placental insufficiency and inadequate nutritional and oxygen reserves can happen. So you would be concerned about that. Meconium aspiration related to asphyxia during labor could happen. Hypoglycemia could also happen. So some of the things you're going to see in assessment findings. So with physical characteristics of a baby that has this, they're going to have a large head in relationship to their body, long nails, large anterior fontanelle, decreased amounts of Wharton's jelly present in the umbilical cord, thin extremities and trunk, loose skin due to lack of subcutaneous fat, dry, flaky, or meconium stained skin. So what we're going to do for this, you try to identify this earlier on in pregnancy if possible so you can intervene, depending on what the cause is. So we're going to assess for respiratory distress, try to assess for any abnormalities of the baby that they have, try to maintain a neutral thermal environment. And then just kind of monitor for some of these other things, like maybe feeding intolerance, monitor their weights, monitor for some of these electrolyte imbalances and stuff. All right, so if a baby's large for gestational age, this means that their weight is above the 90th percentile for his or her gestational age. Usually, these babies have a greater body length and head circumference compared to infants who are appropriate for gestational age. Risk factors are maternal diabetes, that's probably your number one thing, multiparity, previous macrosomic baby, and prolonged pregnancy. So for this, you're worried that you're going to end up having a cesarean birth, for one, that you could have shoulder dystocia, breech presentation, you could have birth trauma, hypoglycemia, those types of things. So that's the kind of things we're going to be watching for. So again, if this baby comes out big, you're going to monitor for some of those things. So monitor for birth trauma, monitor for hypoglycemia. And then, if this baby does have hypoglycemia, we want to provide early and frequent feedings to decrease the risk for that again. We are going to assess the skin color for signs of polycythemia. We are going to observe for jaundice. We're going to watch their respiratory status and make sure they're still breathing okay, all of those types of things. Okay, meconium aspiration syndrome effects, and our answer is post-term infants. So large and post-term infants are likely to pass this in utero, leading to a dangerous respiratory situation. Okay, so this one is talking about hyperbilirubinemia. So this is a risk in preterm neonates. You can have developmental delays if you have this. So with bilirubin, when we're talking about that, we have unconjugated and conjugated bilirubin. So unconjugated bilirubin can deposit into tissues and cross the blood-brain barrier. Conjugated is bound to albumin, and once it's bound, it's water soluble. So it's non-toxic and can be excreted by the baby. So bilirubin cannot be excreted until it's conjugated. So that's kind of what the problem is when you're making too much of it. All right, so with jaundice, some of the things that you're going to see. So you're going to have an increased red blood cell volume in physiologic jaundice. So usually the red blood cell lifespan is 70 to 90 days for a baby. So high bilirubin production you're going to have with this. So the baby is going to try to reabsorb increased amounts of unconjugated bilirubin in the intestines because they have the lack of bacteria, decreased gastrointestinal motility, and increased beta. So they just can't, what am I trying to say? They can't absorb all of this into their intestine because their intestine is very immature, I guess you could say. So they have decreased hepatic uptake of bilirubin, and then so they're going to get this jaundice. So when you have jaundice, you have this yellowish tint to your skin and your sclera of your eyes. And it's funny, like I said with my daughter, I didn't really notice it at first, but then as I look back now, I'm like, what the heck was I thinking? Because when you look in pictures, you can really see it. So risk factors for this. So risk factors for jaundice would be breastfeeding, diabetes, if you're Asian, Native American, or Greek ethnicity, Rh incompatibility, and then some neonatal factors would be excessive weight loss after birth, prematurity, bacteria or viral infection, hypoxia or acidosis, those types of things. So treatment is determined by the level of bilirubin and the age of the neonate in hours. So phototherapy is the most widely used to treat this. So various types of phototherapy delivery systems are available. So sometimes they'll have blue lights, white lamps, halogen lamps. There's all these different kinds that they can use. But it results in photoconverting bilirubin molecules to water-soluble isomers that can be excreted in the urine and stool. So that's kind of how it works. It seems like it wouldn't work, but it does. So you would be monitoring your bilirubin levels, like your blood work, and you should be seeing that decrease quite a bit after that. So infants could be discharged before 72 hours of life, should be seen for a follow-up by the healthcare provider within 1 to 2 days to see if maybe they have jaundice. And like I said, with my daughter, that's what happened. We had to get admitted again. Okay, so other neonate conditions. So they talk about retinopathy of prematurity, some CNS injuries, infection, and Zika. Remember that Zika virus? There's all kinds of congenital abnormalities that we could see with babies. There's a ton of things that could happen, honestly. All right. So basically in this chapter, your major goal is to try and, come up with a way to find these things quick so that you can treat them and that the baby isn't going to be having really bad, outcomes, because you caught it too late. So we want to give really good respiratory care, prevent bleeding and complications from ventilator use because believe it or not, being on a ventilator can really cause a lot of problems. So that's that chapter. That one's kind of overwhelming because it has so much to it. But when I give you your tips to know for the next test, it shouldn't be that bad. I don't think there's a ton out of that chapter. Okay, guys, like I said, if you guys came in late, I don't know if everyone heard this, but I made a ATI quiz for you that I sent to your email. And it's for OB. and it's to help prepare you for next week for our OB proctored. So, you know, for the rest of this week, I want you guys to make sure you're really focusing in on that and making sure you're trying to get a really good score. We want to see, hopefully, everyone get level 2s if possible. If you have questions about what you can do to prepare for that, again, there's a ton of different ways you could do questions. I would just do lots of questions. I think that will help you a lot, especially if you're looking at rationales. And then review your ATI book. I think that will help focus you in on things that are more important. So do you guys have any questions about anything?
No.
I don't think I got the email from you.
You don't think you have what?
I don't think I got like the ATI email from you.
Well, I tried to do that right before I got on here. So does anyone else see it in their email yet?
Check.
No.
Not yet? All right, I'll go look at it again. Maybe I didn't send it like I thought I did, so I'll try to resend.
Okay.
Okay? All right, so we'll get back on here 12:30-ish for our community class and get that over with, okay? All right, I will see you guys later.
Bye.